Good morning. I don't know about you guys, but I'd love to hear hold music like that at the beginning of every Zoom when I'm kind of waiting for things to kick off. I'm Stephanie Winans. Thank you all for joining us today. I am the Chief Growth Officer at Biodigital, a biomedical visualization company. The Biodigital Human is the leading software platform for creating and disseminating 3D anatomy, health condition, and treatment models. So we work closely with industry partners, patients, and providers to help people kind of see inside the body for the first time. I'm really excited about this panel. At Biodigital, we use data to properly model abnormal and normal anatomy and disease. So data certainly close to my heart. Also long-term background in digital health, and joined by some very fantastic panelists today. So excited to get started. I'd love to have us kick it off with introductions so that you guys kind of get a sense of context for who's joining us on the panel today. So Heather, if we could start with you, I'd love to have you guys kind of do a round robin and give introductions. And while you do that, tell us a little bit about the role that data and innovation plays at your respective companies and in the roles that you're in.
Great. Well, thank you, Stephanie. Hello, I'm Heather Cox, and I am the Chief Digital Health and Analytics Officer at Humana. And I joined Humana 3 years ago after 25 plus years in financial services. So this is my first step into healthcare. And if you just look at the title, my title alone, it should tell you how important data, digital analytics, and moving into the mode of future-proofing our business and in order to improve care outcomes and to simplify experiences. That's kind of the whole focus of our organization. And happy to later answer questions about kind of how we're structured, but the group itself, I picked up several interesting teams and skill sets that had kind of been dispersed across Humana, as well as brought in a significant number of folks in the engineering, both software and data engineering, data science fields, human-centered design, product managers. And what you see with this unit within Humana, it looks more like a health tech company inside of a big company than not. So it's been a lot of fun for me. It's been really difficult to jump into something as new and different as healthcare after all the time I spent in financial services, but I've absolutely loved it. And it's exciting to see the impact we're starting to really drive on those better, simpler, connected experiences.
That's great. And what a great way to describe exactly where you sit within Humana. Thank you for that. Brent, do you want to go ahead and tell us a little bit about you?
Yeah, so Brent Lamm, I'm the Deputy Chief Information Officer for UNC Health. I also have the pleasure to currently serve as the Chief Analytics Officer for the organization. I have responsibility for our enterprise IT portfolio, including our Epic electronic health record system and our ERP, or enterprise resource planning systems, and all the various systems and applications around those that run the business of our 14 hospitals and over now 1,000 clinics across North Carolina. But I also, really more germane here, have the pleasure to lead our enterprise analytics and data sciences function within UNC Health. And it's something that we stood up 5 years ago very aggressively, and we're very proud of the progress we've made during that time, catching up in some cases, and we like to think leading in others. I think in terms of your question, Stephanie, for data, I believe fundamentally that data and analytics will be the way that we drive value for our patients in the next generation. We have a very strong mission at UNC Health to serve the citizens of North Carolina. We want to provide fantastic services to promote the health and wellness of our patients and communities that we serve. And better data and better analytics is how we're going to get that done in the coming years.
That's great. Alex, let's go to you.
Perfect. Good morning, everybody. Thank you, Stephanie, for the intro. My name is Alex Vannoni. I'm the Chief Digital Officer at Well. We are an early stage digital health startup. So a bit earlier than some of my colleagues here on the panel. We're a Series B funded company and about 150 employees. We kicked the company off about 2.5 years ago. And really what we're focused on is working with large self-insured employers to very simply manage and improve the health of their employees. And we do that in a couple of different ways. The two primary ways are we offer a concierge service where our members can interact with live people to help them with various issues or challenges that they might be facing. A lot of times this is navigating the healthcare system. Other times it's helping them manage a chronic condition. And then on the other side of the house, we have a digital front door, and that is largely based on providing personalized and data-driven services to folks to help manage their conditions and it's largely based on behavior change. So there's a big behavioral economics component to this, and how do we incentivize and motivate people to make decisions for the betterment of their health that they're either currently not making or just have a hard time sustainably making. And that tends to be one of the biggest areas of improvement for folks when they're really trying to manage their condition, improve their overall quality of life. And we've found that it's a very effective way. We've seen it done really well in other industries, and a lot of what we did, we were actually doing it in the context of larger health organization. Actually, our founding team came from Aetna. We were doing a lot of this at Aetna, and then prior to the CVS acquisition, and when that acquisition closed, we were able to kind of spin out and start this company anew. And to Stephanie's point, technology, data, machine learning is core to our DNA. It drives everything that we do. And to a large degree, it's one of our biggest differentiators in providing a personalized experience for each member that's on our platform. So excited to dig into some of the questions that we have planned today.
Yeah, I am too. I have to say, this panel is like the perfect triad because we have payer, health system, solution provider. I don't know who at the Center for Business of Health set this up for me. This is an exciting panel to moderate. So I'd like to start by talking about health outcomes and the correlation between health outcomes and data. The focus in the industry on data analytics today is really predicated on the notion that more data equals better decisions and therefore, better, more positive health outcomes. I'd like to start with you, Brent, from the health system perspective. Do you buy that notion? Do you believe that more data, always yields better outcomes? What's the correlation there from your perspective?
I probably could get challenged on this. I don't know that always applies. I think in general it does. I don't know that always is the way I would classify it. Never say never or something like that is cliches coming to my mind. I do think it makes a huge difference. I think what we've seen at UNC Health is more different types of data that we can stitch together about a patient really move the needle for us. So if you're just working with electronic health record data, or you're just working with claims data, or you're just working with patient-reported outcomes data, you're going to see benefit for sure. But I think the power of what we're seeing is when you can actually stitch those different types of data about the same patient or the same population of patients together. That's where I think the exponential factor of insight generation comes from. That's sort of my 2 cents.
Yeah, that's great. Alex, Heather, do you guys have anything to add?
Sure, I'll jump in. I think I agree. Not always, because it can get quite messy and hard to really understand the insights. But I will tell you, breaking down silos of data that exist in healthcare, even within a single company, which we are a large payer, as you said, and we're also one of the largest provider systems in the country with our in-home care network, and tapping into those silos and ensuring that we aren't basing all of our work on claims-based view of the world, which is also often and always a retrospective view, and really trying to get into predictive. I would say tapping into trapped data in our world. So things like the clinician's notes in the electronic health record, using natural language processing and those capabilities to go in and use advanced analytics to extract that information that's otherwise trapped and not, you can't find, as an example, social determinants of health all that easily unless you can utilize these new technical tools that will allow us to tap into it. And so I think that's just one great example of really tapping into new sources of data that can really unlock real value in the relationship you have with your patient or member. Brent, you talked about stitching together information on a single patient or a single member. We're building what we're calling the longitudinal human record, which is not just your health record, but all that we know about you and all that you are sharing with us. And think about a world where we start to get into more interactions because of digital health tools or virtual care sessions that we can tap into, remote monitoring, to really start to get a real view of the individual at an N of one is really the power here. So we are getting into a world of more and more data, but we just got to be careful about how we utilize it, how we share it, and how we create meaningful outcomes with it. A move, separate conversation, but really important. The move to modern technologies, and in particular, the move to the cloud, where you can actually have the scalability you need to manage this volume of data, is really, really important sea change for our industry.
Absolutely. Go ahead, Alex.
I was just going to say, the only thing I'd add, completely agree with what Heather and Brent described, and to a large degree, our system is predicated on data. The more data we have, the more value we're able to add to the patient and consumer at the end of the day. So the way that we think about it is, the more we know about the individual, the better that we can engage them, the more personalized the experience that we can provide, and then therefore, the more value that we can provide. And so to Heather's point about the N of one experience, that's really what we're trying to provide. And so the experience, if Heather were to come on our platform and Stephanie were to be on our platform, you would have two different experiences based on what we know about you. And that comes from some of the data sources that Brent touched on, comes from claims data that we get from employers, comes from patient generated data, comes from passively collected data through sensors, phones, wearables that people have. We sort of ingest all of these things and try to build that personalized profile so that we know where your health opportunities are. But we also know what's important to you. What are your goals? How can we use that as a place to start an on-ramp to maybe some of the more challenging things that an individual has either avoided for different reasons, or it's difficult for them to start and then sustain over time. So to a large degree, data is the driver for that behavior change experience that we have. But I also will agree with Brent in saying that it's not the cure-all. It's not an always situation where more data equals better outcomes. I think it's sort of on a continuum, and we try to live on the far end of the continuum where more data equals better outcomes most of the time.
Yeah, certainly breaking down silos and actually taking action based on the data being key for any industry, but especially true in healthcare, where you do have all of these different sources of data coming in. So Alex, you touched for a moment about patient engagement, and I'd like to kind of move there in terms of, where does the data come from and what do we do with it? So obviously patient activation, patient engagement is key. Without that, there's really no data to even have the opportunity, I love that term, health opportunity, by the way, to impact behavior and drive positive health outcomes. So I'd love to hear how you view, and you too, Heather, the connection between, patient engagement and outcomes, and how you view that challenge.
Yeah, so for us, engagement is a first order challenge. We need to get people activated on our platform for the first time, and then we need to sustainably engage them over time, because everything that we build after the fact is irrelevant if we can't get people in and we can't get them to continue to come back. So a large part of what we're trying to focus on is, again, I talked about personalization a little bit, and that is driven by data and what we know about the individual. And that's critically important. But there's another element of this, which is the experience that we're building. And to a large degree, we are trying to hold ourselves at par or at the level of other consumer experiences that every person has in their everyday life. This, the way that they experience Amazon, the way that they experience Uber, These sort of easy use, intuitive experiences are key to kind of bring people in and get them to keep coming back. And so that sort of consumer facing experience combined with all the data and insights we have on the back end helps us solve some of that engagement problem. And then from there, we really start to focus on sort of behavior change and getting people to move from their current state to sort of the gold standard of where they could be based on their demographic and diagnostic circumstances.
Okay, there's a really good, actually a couple of really good questions coming in, which is, I'm glad you guys found the Q&A because I forgot to mention that I'll be kind of monitoring this. So the first question is for you, Alex. It says, as a business, how do you at Well differentiate value over what could be delivered internally at a payer who has primary access to patient data and the direct, payer member relationship?
Yeah, so for us, this is part of the reason why initially we're focusing on self-insured employers. To a large degree, they have the financial incentive in the same way that payers do to better manage the health of their employees. If they can sort of keep services rendered or services consumed at a consistent place, or even do better than they expected to do at the beginning of the year, all of those savings come back to the employer. So we work with them on that financial incentive to say, if you use us well as your digital front door, as your concierge, as your chronic condition management platform, we can help you save cost over time, add value to your employees, but also to your bottom line, because it's not just about trying to manage the healthcare services that employees consume. It's also about ancillary benefits to the employer around increased productivity, reduced absenteeism. And all of these things are sort of the outcomes that we tend to focus on, and the byproduct of helping them not just focus on sort of the top 5 to 10% of highest cost and highest risk employees. We try to build a platform and a solution that's relevant to everybody, young and healthy to older and managing chronic conditions. And part of the reason for that is everybody, no matter who you are, has some kind of health goal, is trying to work on something, and eventually over time need to engage the healthcare system at some point. And we want to establish that relationship as early as we can. And so again, back to the value question, part of the reason that we're working with self-insured employers is because they have the same financial incentives as you would see sort of on the payer side or the government side via Medicare and Medicaid.
Hey, Stephanie, it's Heather. Would you mind if I jumped in on that as the payer?
Absolutely. Yeah, I'd love you to. Go ahead.
Yeah, so I think the challenge can be with more mature companies that have grown up over many years, like a Humana. It's hard to drive end-to-end innovation at times. And so having partners like a Well, other digital health ecosystem assets is a really powerful proposition for us. And the way that most companies are now trying to bring these services to bear, you're coming with a platform approach where you have producers and consumers, and you can be a producer on my platform and I can be a consumer of yours at the same time. That's a really powerful value proposition for big companies like ours, where integration, if we can lower the cost and the amount of time it takes to integrate because of great new players in the ecosystem, then so be it, right? And it's the combination of the things we build that we think are really important for us to own, and how we partner to bring alive the full set of services in the value chain. So it's great to have the combo, and the more that we create interoperability in healthcare, the more frequent you're going to see those kinds of collaborations at scale.
I hate to ask, Stephanie, but can I jump in there now from the provider side? So yeah, I mean, that's just to build on what Alex and Heather just said. I think for us, historically, a lot of healthcare IT vendor solutions have been so siloed. We sort of silo is a theme here, I think, of our conversation so far, but they've been siloed in the setting of care, the specialty of care, et cetera. And so what we're really interested in, a lot of what Alex is talking about is very exciting to us. What he and companies like Well are doing, is we're starting to see the healthcare IT vendor space really do embrace that interoperability word that Heather mentioned. That is so critical. And for us, what a lot of that boils down to is the ability to have a patient engage with UNC Health, in our case, digitally across the various settings of care, across the various primary care, specialty care visits, critical access or emergency visits, urgent care, hospitalizations, and being able to do that and interact with UNC Health seamlessly through that process. Because as my boss taught me a long time ago, she's a nurse and came from the clinical side before moving into the IT space. You know, so many of our healthcare systems across the country are so ingrained in the setting of care, the specialty of care, and we've got to continue to break down those barriers. And I think digital technologies can be a way to help patients, help us break those down. And so I'm really excited about the journey that I'm seeing our system take in this regard over the past really just 3 or 4 years, quite frankly, in my opinion.
That's great. And actually, this kind of lends itself to one of the questions in the chat in terms of the total ecosystem and the total patient continuum, which is why I love all three of you being on this panel. But the question is, because you guys are across the continuum of care and representation, how do you think about ways payers, health systems, more consumer and enterprise health service solution providers can kind of like knit things together and create that broader health record? And what are the challenges to kind of knitting those things together?
I'll jump in and start, and then we can go from there. I think there is a huge opportunity because no single part of our ecosystem is going to be solved by one of us. And so this term interoperability, if you've spent 2 minutes in healthcare, you've heard the term. It's really important. It's more than important. It's critical to our success. And frankly, I was stunned to come into an industry where we had to wait for our regulators to mandate that we do the right thing in order to make patient records accessible and transferable and transportable. And so this is a next great evolution for our industry. And frankly, we need to even go further. But when you think about creating the ways for the data to flow seamlessly through the system, because the patient or the member owns their own data and they can direct it to where it needs to go, suddenly you have to be able to very elegantly and intelligently route you to the next best place. And we can, whether it's digital experiences or physical in-person experiences. And so you think about things as just, admit discharge data that is available in real time. As long as it's actually made available from the hospital systems, we can tap into that and get you faster to your next best point of care post-discharge, so that we can have more interactions with you and maybe in the end create, yes, more short-term expense on more interactions, but longer-term better health outcomes that reduce the overall total cost of care. And I think that's what we've all got to be focused on, and how we all need to be pushing the industry on further interoperability, data exchange, helping one another get more intelligent. Because I think, the margins in this industry are pretty interesting. They're thin in most places. And so you're not going to win on driving, the revenue sources of revenue are going to substantially shift. And what we've been making money on is going to shrink and shrink and shrink. So why don't we all start to figure out how we create new value pools together? And we do that through lowering waste, getting rid of waste, driving better overall health outcomes. And we do it together with each part of the ecosystem. So I'll get off my soapbox now. Sorry.
From my perspective, you nailed a lot of the challenges that we see. One thing too that I think is important to note from an interoperability perspective is the new rules on interoperability that went into effect on July 1st that now put a little bit more sort of control in the patient's hands, where they can request information to be shared from a payer to a third-party entity like a well. That also opens up more opportunities for us, because like I said, we started with self-insured employers where they, to a large degree, own a lot of this data from the payer or from the pharmacy or the PBM. and they can facilitate that connection between those entities and us. Now we have a little bit more of a direct line where all it really takes for us to set up a connection with a Humana or a Blue Cross or an Aetna is for one patient to request those records, become sort of an approved app within their ecosystem, and then connect with the API so that the flow of data between a payer and a digital health entity like us now becomes viable, where that was not the case 6 months ago. And that opens up a lot of doors and sort of gives us an opportunity to work more closely with payers, to work more closely with health systems like UNC Health. But more importantly, it allows us to approach the patient care continuum very differently than we have been able to in the past. So I think we're starting to see some of this progress that we've all been hoping for. This is a big step in the interoperability rules, sort of pushing us in the right direction. But it's certainly a benefit, not just for smaller companies like ours that are trying to provide some of these new solutions, but I think it also changes the game for Heather at Humana and for Brent at UNC.
Yeah, and if I could just add on to that, I think, and sort of back to some of Heather's point too, I think the alternative payment model regulation changes and positive momentum, I think, is really deserves a lot of credit for what we're seeing in terms of the opportunities for health systems like UNC Health and payers like Humana to partner more deeply around a membership or patient population. I think the rules have changed. They're still changing. We need them to change more, in my opinion. But I think we've got a lot of really good momentum. And, you know, for us, our value-based care arrangements are, you know, the centerpiece of how we're thinking forward. And I think that interoperability is at the center of those conversations, and technologies like Well and others are going to play a key role in how we actually manifest that as value to our patients.
That's great. Talking about kind of how things have accelerated in the last year. I know we're all really tired of words like COVID-19 and pandemic and all of these things. However, there's a question in the chat, and this is also something that we had talked about when we were looking at how to frame up this panel discussion. Obviously, the pandemic has accelerated the adoption curve as it relates to digital health and the way the entire ecosystem, behaves. So what adoption do you guys think was more of a short-term blip? What do you see as sustainable impact on the trend line that we see moving in terms of digital health adoption? I'm curious to kind of get your opinion on that. And if we want to throw interoperability progress in there as well as COVID-19, I think that's totally fair and part of the rapidly changing landscape. So curious to hear your thoughts.
I'm off mute, so I'll jump in. Listen, COVID-19, as terrible as this has been for everyone, there were some silver linings. And in my case, the silver lining, one of the big ones, was around the digital health and suddenly the shift in adoption by not only end consumers, but by providers as well, right? Because you look at like telehealth and the impact and opportunity that came around because of COVID-19. Let me just offer some statistics to kind of give you guys a sense for what we're seeing. Pre-COVID-19, so call it January of 2020, 0.4%, a little under that, is what we saw in utilization of telehealth in our membership base. And that stayed consistent over the course of 2 years prior to that. So 0.4, at the height of the pandemic, call this now April 2020, we were up to 42%, right? When you had provider offices closed, you really couldn't get out, people with chronic conditions. We also, separate note, one of our largest base is Medicare Advantage beneficiaries. And so we're talking about 65 plus primarily. So chronic conditions is a real big issue, and not being able to see your doctor for months on end is a really bad situation. And so 32%, even with our membership base. You look at behavioral health, and prior to the COVID-19, it was 4% engaged via telehealth. That spiked to over 60% and is now sustained at 42 or so percent. So we are seeing sustained activity. Our telehealth kind of for primary care and specialty visits hit that height of just over 30 and is sitting at 14 or 15, but 0.3 to 14 is a significant lift. And now our job, quite frankly, for all of us is to get it from 14 up to 30 plus. I think that has got to be a core focus. And here's why. I think what we see is the opportunity with things like telehealth being more of a norm, remote monitoring and patients sharing their information back with their provider or even their payers. More interactions are actually a good thing in the healthcare continuum. And we have always, from what I'm observing, we do our best to minimize the interactions when we in fact should be looking at what is the aperture for all the types of interactions and how do you build deeper engagement, better relationships, more trust between a clinician and their patient so that you can get to those better health outcomes. I think that's the huge opportunity. And I'll offer a couple of examples. So coming from financial services, there used to be a day when not so long ago, we would all go to the teller to go get money out of the bank or put money into the bank. We would physically hand money back and forth with a physical human being. This was not that long. This is the mid 90s. Okay. You then have the whole notion of an ATM coming to the street. And now you have a teller out on the street that's automated. Well, then you start to have the World Wide Web emerge and you can start to do things in a new channel. You also had the advent of better voice-driven and intelligent IVRs. And the big concern was, are we raising the number of interactions? And this is our cost problem. What does that mean? Well, guess what you get on the other side of it today? All of us have these things and we're checking our bank accounts every couple of days, not once a month. We're on top of our interactions. We're getting intelligent information on how to use our money more wisely. Like this is the opportunity, the exact blueprint we have to apply in healthcare, where the more interactions, the lower cost interactions get added to in person. You can never take the person out of it. What can we do to really build a more sustainable health ecosystem? It's pretty exciting.
I'd like to take a parallel conversation to the question, Stephanie, about COVID-19. I think agree with everything Heather said, and especially the virtual care, telemedicine comments, and what we saw reflects very similar to what Heather shared. I think the other thing for us, if I could sort of go a little bit of a different tangent on your question, we saw an acceleration of our analytics program because it was by necessity. So we stood up 30 plus operational and clinical dashboards during the first 6-8 months of the pandemic. We created, probably half a dozen to 10 new predictive models around critical supplies, PPE, hospitalizations, virtual care, and volumes, et cetera. And the result of that is the level of trust, and that's a huge word in my opinion around analytics and health, but the trust factor of analytics and what data science can do within healthcare took a stepwise order of magnitude leap, in my opinion, during the pandemic, because it was necessary. We couldn't operate at the volume and scale that we had always operated. We had to operate differently very quickly. And the clinical leaders in our organization, operational leaders in our organization, frontline care teams, they quickly began to rely on and trust the analytics that we were putting in front of them as a result of the pandemic. And now that's something I think that is sustaining, and I'm really excited about that. I think we're going to see adoption, credibility, trust in the analytics in healthcare continue to rise over time as a result of what we saw during the pandemic.
That's great.
Yeah, I think that's exactly right. Just one quick thing to add, Stephanie, what Heather touched on with interactions and having more interactions sort of leads to better relationships. Brent's comment about trust, all of these things are true. The interesting thing about this is I'm loving hearing Heather talk about this, because payers did not talk this way that long ago, right? It was about sort of managing utilization, working on steerage. How do we sort of reduce costs in a way that doesn't always benefit the end user? And when we were at Aetna, we were trying to have that same conversation and drive change that way. What it's allowed us to do now is, early stage digital health companies like our own now have more of a role to play, right? We have more of an audience. that didn't actually exist not that long ago. And this sort of comment on interactions is so key, because if you think about what actually drives improved health outcomes and drives behavior change, drives different decision making for the end user, part of it is making them feel like they're owners within the whole ecosystem. And I think that too is something that is a newer phenomenon, and that's been expedited by COVID, has been expedited by the adoption of technology, and we're seeing it across the board. And the only way these things start to change is, payers need to get on board, and they are. You can hear it in everything that Heather's saying. Same thing with health systems, and same thing with employers. Part of the reason why we've had so much success on the employer side of the fence is because employers are realizing too that they need to invest in their employees differently. They need to offer different services. These are some of, to use Heather's term, these are some of the silver linings of COVID, is we've been able to see more of that adoption, and as a result, have more of a presence with employers, and then over time grow into some of those other segments that we talked about.
Yes, Stephanie, would you mind if I jump back in? Because I really am excited I didn't realize the value of having these 3 different parts of the ecosystem on the same panel. This has been great and super informative. But there's a real challenge that has also arisen out of the pandemic as it relates to things like the emergence of digital health. So all of us were acutely aware of the digital divide for students as we were going through the COVID pandemic, right? And getting kids access so they could actually continue to learn became a very front and center topic. The topic that we aren't hearing enough about is our older Americans. Older Americans are willing and are using digital tools, but there is a great digital chasm that has arisen. We have 21, we did a study with an organization called OATS, Older American Technology Services. And we ended up giving a large grant out of our foundation to partner with them, because what we found is 22 million seniors over the age of 65 do not have access to the internet. There is no broadband. So this is an access to care problem at this point that we structurally have got to find ways to solve, or the value of digital is going to create more inequalities when it should be actually improving the access to care. And so this is something, we're forming coalitions across public, private, government, trying to pull in the telecoms and the device manufacturers to make sure that we're doing something to solve this very critical issue that faces our older Americans.
So Heather, I have to jump in. You're touching on one of my passion points, and something that Governor Cooper and his administration, I'm proud to say, are trying to make progress on. And very quickly, Stephanie, I promise, but a lot of people don't know this, but North Carolina has the 2nd largest rural population after the state of Texas in the United States. And this is a real issue in our state that Heather's pointing out. This is not somewhere else. This is in North Carolina.
So how do you guys view the virtual care stats that you both were mentioning were aligned in terms of UNC Health and Humana as it relates to rural population and over 65? Because you mentioned chronic condition, the 65 subset of that. Obviously you had a rise in virtual care, but when you break that down by age, you see some inequities in the data, but do you see massive opportunity there? And how do you pull in? So you mentioned pulling in, infrastructure in terms of, telecom, cable companies. Who's footing the bill for that, right? Like when we think about, who benefits and who pays, I'm just curious about how you guys, it's a very real challenge, right? Like the patient obviously benefits, but there's a reason the patient isn't already paying for their own broadband. How do you guys view that challenge? I know
it's
a loaded question.
Yeah, this is going to be a combination of companies doing the right thing, regulation changing. So prior to the emergency status of COVID-19, we weren't allowed to give devices to our Medicare members. It's considered a benefit, and then it's an unfair advantage amongst plans. Well, are you kidding me? Like, this is like, we have got to change our stance on basic things like that, or we're not going to get anywhere. But we also then have to bring in the various parts of the private ecosystem that, device manufacturers, I said, organizations like Oates that are actually teaching people how to utilize technology once they have it, allowing us to be able to get devices in people's hands, ensuring that we can access people in their homes or wherever they are. So whether it's rural or city, this is a problem. Rural is a huge issue without question, and it's emerging bigger and bigger. But this is a problem kind of in every city and every state of our country. And so this is a really important one that we've got to keep chipping away at. And I do get on my soapbox about this a lot. And I hopefully can recruit more people each time I do to come to the table with their resources and their reach to make sure that we start to solve this. But we are trying, we have a goal of getting 1 million more seniors online in the next 3 years. And so that's not solving, but it's certainly taking a dent, and we're putting a dent into this problem and hopefully creating a framework by which we can repeat that year over year.
Yeah. So if I could add to that, Stephanie, I did a podcast interview a few months ago, and I had a similar question, and I honestly was not prepared, and it dawned on me I need to think more about this and how do we respond to it. I think I don't think there's a single answer. I think it's part of the solution is economic development. Part of the solution is private partner, private public partnerships. I think part of the solution is also potentially additional infrastructure investment at the government level, various levels of government. I think part of the solution is also realizing that, as more digital outside of healthcare, more digital services and consumer products are made available, the demand can increase, and we'll see, the networking, cabling infrastructure, sort of continue to expand as a result of following the economics of the equation. I think all of these things are going to have to play a role, and I think healthcare needs to be a loud champion and a voice of advocacy in this space.
Yeah, and one quick thing to add too, the same challenges that Heather described from a Medicare regulation perspective and what you can and can't give to individuals was a big challenge for us, right? A big part of what we do on the behavior change side is driven by incentives, both monetary and non-monetary. And so that was a huge hurdle for us to get over. And in the beginning, we were thinking, well, maybe we don't quite go down the Medicare route as a result because there's too many challenges there. What we ended up doing is one of our early clients was actually GoHealth, which is a Medicare marketplace. And we found two things. One, that for those that do have access, or we're a mobile first digital health company, right? So our whole platform is built on having a device, having access to internet. What we found is for those that do have access, and if they're using GoHealth, a lot of times that's kind of a captive population because they're using an online portal to sort of find the right Medicare plan for them. We found that they're not only sort of willing and able to embrace technology and digital platforms, but they're pretty savvy. They know what they're doing to a large extent. I think a lot of this is driven by one of the best ways they can stay connected to family members like grandkids. And so we saw sort of more of a positive engagement with that population than we expected. Now, there were certainly challenges. We found that rather than interacting with our member services via chat, which is typically how most of our members do it, they were calling in. But as long as we have the right channels in place, we found that audience is one of the most in need audiences. But for those that do have access, they're much more engaged than we originally anticipated. And one other thing, just quick thank you to Heather for all the work you guys are doing to get more people connected, because obviously downstream it helps companies like ours reach more people who could benefit from our services.
That's right. There's a question in the chat kind of related to this conversation around incentives. And so when we think about some of the conversation around, who owns the data and putting the power of a patient or a consumer's health data in their hands. So that's, certainly part of the importance of having consumers managing their own care. But then talking about incentives, you've got this other side of the coin, which is great. They have the access and ability to own their own health data and be an active participant in decision making, but not everybody is motivated to do so. And so how do you view incentives? I'm curious to hear all three of your thoughts because you're in different corners that have, certainly different opportunities and challenges on that front. But how do you view incentives? The question in the chat is specific to payers, and I'd like to put employers from your perspective in that same bucket too, Alex, but from a solution provider to a payer or an employer or to the health system or a specific provider in terms of actually, incentivizing patients, and you can use that term loosely, but to really be an effective steward of their own care. How do you guys view that, opportunity and challenge?
Well, if I could just go share my thoughts first, and then Heather and Alex can certainly probably provide better insight. But I think this is a key part of what I mentioned earlier when I talked about the advent of the alternative payment model regulations and arrangements. I think it's probably the biggest aspect of it, which is aligning incentives between the payers and providers so that we are as a unified front to provide incentives and services to patients or members in the context of a payer. I think the alternative payment models that we're seeing now allow us to collaborate in ways that we couldn't before or didn't think to before. And as a result, we're providing a unified front to, or unified set of services in many cases to our patients and members. And I think that's where incentives is really going to make a difference. I think we got to now figure out how do we get those patients to fully engage and more deeply engage.
I'm cheering, Brent, because Humana being on the forefront of value-based care and driving, provider systems and partnerships that lead to more value-based care is a really important part of our evolution. And what we see is a true difference in what value we can bring to the equation as well. But we've built things like tools to, leveraging advanced analytics and putting together payer and provider data and getting it real time into the hands of the providers in our system, whether it's our own clinics or the clinics we have JVs and alliances with, is really important because we can also give you clarity on who you need to prioritize, who you should be talking to and how you should be getting them either into your office or onto a phone call or onto a video so that you can help them, again, manage their chronic conditions. And we're all incentive. When those incentives are aligned across that part of the ecosystem, now it's a matter of how do you get the end patient to have more ownership and teach them how to take better care of themselves. And so I agree, we've got more to do. We obviously, as Alex and I talked about, there are limitations on what we can do to quote incent, but wellness programs in general, I think are one of the most important engagement vehicles we have. And so think about what Alex's company delivers, think about a product that we have in market, getting people to care about the small things. Go get your flu shot. Gosh, if you could just get your flu shot, right? It's a big difference in your cost of care this year. If you walk 10,000 steps today, how do we reward you? Well, rewarding you could just be a balloon, a balloon on your screen coming up and congratulating you for 10,000 steps. It's doesn't have to be monetary, but it's got to be behavior shifting. And so that's where I think, again, these digital tools, we suddenly have an opportunity now that we've all come into acceptance of these things. How can these gentle nudges, Alexa sitting in your kitchen telling you, my Alexa's about to go off. I should not have said that.
I was just thinking that
on me. So, how do we get you? Did you take your medication at 11 this morning? You were test scheduled at 11. Did it happen? Just these gentle nudges can actually really do a lot to shift the dynamics. And so that's where digital and analytics, the combination of the two, right, are going to be really important for us.
Yeah.
Absolutely. I know we have 1 minute, so I'll try to be brief. This is the core of everything that we do. The background of our company, our CEO is a behavioral economist. He was a professor at Harvard Business School for a while, then ran Caesars Entertainment in Las Vegas for 15 years, brought a lot of those principles to the world of gaming. And then he said he wanted to square up his moral balance sheet. And so then came into the healthcare space to bring that same perspective and say, well, people look, there's a really good study. I failed to mention this. My background is in public health, and I went to Johns Hopkins for graduate school for that. And the Kaiser Family Foundation does a ton of really great research in the public health space. And there was a study they did a number of years ago that talked about what are the biggest influencers on longevity, on life expectancy. And the breakdown was very simple. 10% of what affects your life expectancy happens in the traditional healthcare space, right? You're broken, you need to be fixed, you go to a hospital or a doctor to be fixed. 20% is due to your environment and where you grow up. 30% is due to your genetics and genetic predispositions. 40% is due to decisions that we all make or don't make on a daily basis. And that's where we try to live. Biggest piece of the pie. The problem is if we as individuals had enough self-motivation to really tackle these things on our own, a company like Well wouldn't need to exist. Incentives wouldn't need to exist, whether monetary or non-monetary. And so these are, in our opinion, sort of critical to getting people over that activation energy to really not just tackle these things when it's the beginning of the year and this is why gym memberships spike in January, because it's the new year, new you. I want to work on my health and fitness. We want to get people in the door, certainly when the time is right like that, but we need to have it be sustained over time. And incentives are a big piece of getting people, to Heather's point, to get their flu shot. Got mine yesterday, great. And to do a lot of those little things that are preventative in nature, but also that sort of really require us to say, I'm going to work on my sleep. I'm going to work on my mood. All of these things have an effect on how I manage my diabetes. It's not just about nutrition, diet, and exercise. So that's sort of the heart of what we're doing. And that's what really excites me about a lot of the things that we talked about today.
Yeah, this is great. And I hate to cut off such fantastic conversation, but I feel like that's my one job is to just start and end on time and let you guys do your thing. So I just want to say thank you to the three of you. This has certainly for me been very thought-provoking discussion. I've really enjoyed it. So hopefully, and my assumption is that the audience really has too. I'm sorry we did not get to all of the questions that you guys were asking, but thank you for kind of helping me move the content in the direction that you guys are most interested in. For our audience, we will now move into the second round of breakout sessions. If you're interested in session 2A, which is practicing health and well-being within healthcare companies, stay here, don't go anywhere. If you are interested in 2B, which is public trust in the healthcare sector amid and beyond COVID-19, there is a link in the chat that Aaron Leach just posted. You can click that to join that panel. Those panels will begin in 10 minutes, so you have time for a little break. Thank you guys, thank everybody, and have a great weekend when you get to it.